Hello everyone, my name is Jose Gomez and today I will be presenting my capstone project titled Evaluating the Ryan White Program in Pennsylvania, HRSA Metrics, Program Efficiency, and Social Equity. First, allow me to provide some background information into the Ryan White Program. The program was created in 1990 by the federal government as its official domestic response to the HIV/AIDS epidemic that was ravaging the country and affecting people from all walks of life. The history of HIV/AIDS in the U.S. is one that was initially grounded in misconceptions and divisiveness. It wasn't until 1983 that HIV/AIDS was identified as a transmissible disease in its own right. As an increasing number of individuals were diagnosed with rare diseases that target those with weak immune systems, a trend was uncovered and the diseases were grouped and labeled as opportunistic diseases. Since a majority of the individuals affected at first appeared to be homosexual men, or those who divulged at some point that they had engaged in sexual intercourse with other men, the scientific community hypothesized that this must be some sort of gay plague. The media took that theory and spread misinformation about the origin and the methods of transmission of the supposed gay plague. The political context is also important to consider. This was a time when the Reagan Revolution was in full force, the country had aligned itself with more conservative political views, and the Christian evangelical right was crucial to those conservative victories. This gay plague theory was exploited and played into their rhetoric against what they perceived to be moral corruptness that needed to be rectified. When an increasing number of individuals that did not fit the gay plague model began to be diagnosed with HIV/AIDS, the theory was expanded to what became known as the 4H risk group model. According to this model, those at the highest risk of being infected or infecting others were homosexual men, hemophiliacs, Haitian immigrants, and heroin users. Heterosexual men who told their healthcare providers that they had not engaged in sex with other males were accused of not being forthright, and heterosexual women were told that they must have at some point engaged in sexual intercourse with a male that had sex with males. It was not understood at the time exactly what bodily fluids could and could not infect an individual. People feared that the disease was transmissible even through sneezing or sharing silverware. Obviously, our understanding today of the modes of transmission are much more improved. Nonetheless, it is important to recount that history because of the deep impact that it had in marginalizing entire vulnerable at-risk segments of the population and feeding the vicious cycle of transmission. Many individuals feared finding out their status for fear of discrimination or retribution from their employer, their landlord, their family, friends, and their community. For many years, instead of encouraging individuals to seek care, people feared that doing so would be tantamount to some sort of scarlet letter that could brand them in front of their peers. In my capstone project, I seek to develop a program evaluation model for the Ryan White program and similar programs whose intended purpose is to provide assistance to vulnerable populations. I focus my evaluation on the program in Pennsylvania. It is best to conduct a state-by-state analysis of the program because the program is structured to provide grants to each individual state and territory to provide healthcare services and treatment to their low-income HIV/AIDS populations. My program evaluation asks 3 questions about the program in Pennsylvania. Is it effective? Is it efficient? And does it promote social equity? I answer the first question of whether the program is effective by adopting the criteria utilized in prior program evaluations into the Ryan White program, and by the Health Resources and Services Administration, which is responsible for administering the program. HRSA measures 2 metrics: viral suppression and retention in care. to answer whether or not the program is being effectively administered. Effectiveness is defined as whether the stated goals of the federal government's 5-year national HIV/AIDS strategy are being accomplished. These are to reduce the number of people who become infected with HIV, increase access to care and improve health outcomes for people living with HIV, reduce HIV-related health disparities, and achieve a more coordinated national response to the HIV epidemic. Retention in HIV medical care of program clients is defined as people living with HIV who had at least one outpatient ambulatory medical visit by September 1 of the measurement year, with a second visit at least 90 days later. Viral suppression is defined as a person living with HIV who had at least one outpatient ambulatory medical care visit and at least one viral load test during the measurement year, and whose most recent viral load test was less than 200 copies per milliliter. The connection between retention in care and viral suppression is that it is necessary for a client of the program to remain in the necessary care and treatment and receive regular follow-ups in order to achieve viral suppression and maintain it. The two metrics are inextricably linked to one another. The findings of my research reveal that Pennsylvania reduced the number of new HIV/AIDS transmissions from 2009 to 2013, the years for which there is available data. In 2009, there were 1,829 new transmissions, and in 2013, this number had dropped to 1,425. However, the year-to-year drop in new transmissions has decreased sharply. From 2009 to 2010, the number of new transmissions fell by 156. But from 2012 to 2013, it only fell by 64. Data on retention rates and viral suppression rates are available from 2011 to 2013, and the findings show that when compared to the aggregate Ryan-White programs in the U.S., Pennsylvania outperformed them in both categories every year. The reason why it is important to consider efficiency, that is, whether the program is maximizing its outputs for every input, in this case dollars spent, is because public agencies are under increasing pressure to justify their activities and programs by showing a track record of achieving results at the lowest possible costs. They are expected to do more with less, and use taxpayer money responsibly in the pursuit of achieving the agenda of the government. The findings of my research show that the Ryan-White program in Pennsylvania, when compared to the aggregate RWP programs across the country, spent on average $1,031 less to provide the same services to each individual client. Furthermore, on average, Pennsylvania spent $1,372 less than the national average to successfully retain an individual in HIV/AIDS care. Where it can be said that the program is not efficient is in the cost of reducing new transmissions. Due to the sharp decrease in the reduction of new transmissions realized from year to year, the cost of each new transmission has almost tripled from 2010 to 2013, from $555,000 to $1.2 million per reduction. Lastly, this project introduces consideration for whether the program promotes social equity. In other words, it seeks to learn what steps the program is taking to reduce the long-term disparities in HIV/AIDS transmission and outcomes brought about by discriminatory rhetoric and policies throughout the years. The data shows that Latinos are underrepresented in the Ryan-White program of Pennsylvania. While they make up 15.4% of the HIV/AIDS population, they only accounted for 13.5% of the program's clients. African Americans and women, on the other hand, are well represented. African Americans make up 48.7% of the HIV/AIDS population and 54.7% of the program's clientele. Despite African Americans making up a majority of the program's clients, they still continue to be disproportionately affected by mortality from HIV/AIDS, lower rates of viral suppression, and lower retention and care rates. On the other hand, while Latinos lag in being represented among the program clients in proportion to their percentage of the overall HIV/AIDS population, their viral suppression rates was commensurate with that of the aggregate HIV/AIDS population at 81% in 2013. African Americans, on the other hand, had a viral suppression rate of 78%. Data on viral suppression for males that have sex with other males is available for 2012 and 2013, and for both years, it exceeded the viral suppression rate of the state's whole HIV/AIDS population. The relative success in maintaining viral suppression for these two groups may provide potential lessons to program administrators that could help improve the viral suppression rate of the most affected community, African Americans of both genders. The findings of this performance evaluation provide information that has critical implications for the HRSA as the federal administrator of the Ryan White program, for Congress, which holds power over the level of appropriations to the program and are doing so increasingly on the basis of proven results, and state-level administrator of the program's constituent parts at the level of the Pennsylvania state government, including nonprofit contractors such as the JHA, whose interests are tracking results, identifying and correcting shortcomings, and establishing best practices for all grantees to emulate. Watchdog groups concerned with the efficient use of taxpayer money and those concerned with achieving and maintaining the representation of traditionally marginalized and underrepresented groups can utilize the findings of this report to support their argument. While past research has either focused on evaluating a program on criteria centered on indicators set by the administrators of the program, such as the HRSA, or solely on the returns of the programs per dollar spent, this paper introduces a model that balances the need to consider both categories of measures with the obligation of bureaucracies and their programs to prioritize social equity, particularly when their work involves responding to an issue that developed in large measure due to socioeconomic inequity. I make the following recommendations to correct the shortfalls in the areas of efficiency and social equity. In order to increase efficiency in terms of measuring the cost of reducing new transmissions, it is necessary to bring the levels of year-to-year decreases back to levels experienced in 2010. Accomplishing this requires prioritizing prevention, education on safe sex practices, identifying and targeting screenings and health services in disadvantaged areas. The Minority AIDS Initiative provides grants to combat the disease in the hardest hit low-income metropolitan areas. Administrators of the program at the state level must use the evidence of disparity and present a strategic plan on how they are going to reduce these in order to secure more MAI funding as part of the Ryan White program. Other recommendations that I make are establishing strategic relationships with influential leaders and institutions in the African American community, in those areas identified as the most afflicted by the disease, such as Philadelphia in the case of Pennsylvania. Networking and cooperating with groups that converge the goals of improving the overall condition and advocacy of the LGBT community's rights and combating the HIV/AIDS crisis in that community, such as the Human Rights Organization. Monitoring the performance of individual grantees and creating financial incentives for them to track, develop strategies to retain their clients in care, and achieve higher retention rates. Thank you everyone for taking the time to watch my presentation.